Thank you very much, Kate.
Thank you.
It's all set up. Thank you very much for that kind introduction and for the invitation to give you that lecture this morning here in Geneva. Thanks for all those people who turned up. Also, welcome to all those guys who are watching us on the internet. Kate mentioned it. We know each other for quite a number of years. What should I say about myself? I'm dedicated to digital health since really that number of years, as you can probably tell by my gray hair. So you mentioned the two European Union projects we did, Mobi Health and Health Service 24. That was also with Dimitri Constantas when you were all at University of Enschede in the Netherlands. If anyone has some spare time and wants to go back to the Stone Age of digital health or mobile health, as it was called, then you might read through those two projects.
Correct, and I was showing an example of the Mobi Health.
Really?
Yes, you remember I was showing you the first mobile health with a lot of cables.
Yes.
You remember?
Yes.
And a clinician from Cyprus. And there was a photo of him. I asked him for if I could use it later. And you remember there was a respiration rate, oxygen saturation on the clip, and the box and the Bluetooth and the PIN codes, and it was so complicated.
It was so complicated, but I mean, it was at that point in time. I mean, the whole thing was really bulky. You had these cables and massive sensors and everything on your body, but it was. Still, it was the best we could get at that point in time, and
we got the data too.
And we got the data, so we really did patient monitoring, remote patient monitoring, and it did work. So as I said, it was a bit of Stone Age, but it worked, and we were at the forefront really of innovation at that point in time.
Yeah, wonderful.
Yeah, good old times. Yeah, but anyway, what else can I tell you about myself? I'm not a computer scientist. I studied business. So that's you will not hear any technical stuff from me today. It's rather the healthcare context, the political context, and the user context most importantly. So I started my career in the pharmaceutical industry and medtech industry with Roche Diagnostics, and then went back to another pharma company in Germany, which is long gone, Schwarz Pharma. All these positions were in product management, international marketing, but since 22 to 2002, 2003, I went more and more into digital health. That's where we met with the projects. I was with Ericsson at that point in time, when Ericsson said, how can we, use our mobile knowledge for different industry areas? Healthcare was one of them. So since then, I stayed in digital health in other various positions and functions, with stakeholder organizations such as HIMSS, Healthcare Information Management Systems Society, which is pretty big in the US, less known in Europe. And since a while, I set up my own company in Germany, where we are consulting startups on the one side, but also established players like life sciences or insurance companies on the other side, when it comes to creating their digital strategies, creating their go-to-market strategies, business models, and all of that. Also internal structures and processes and value chains and so that. I also do invest in some startups, sometimes when I have the money, sometimes. So
now we know where to find.
Some
of our students might be interested.
I probably shouldn't have said that. But anyway, that's
angel investor.
On a very moderate basis. So that's a little bit about me.
Can we just say one sentence, because we had this discussion about Ericsson and Ericsson as a provider of network infrastructure, and then getting into this mobile health, and it was great for them. The idea was great because they're a provider of infrastructure and they're looking for killer apps, right?
Yeah, right.
So
that was where they came from at that point in time, and the idea was good, as you say. They dropped it after a while, unfortunately, as well as the mobile operators like the Vodafones of this world dropped it.
And the Orange speaker.
Or Orange, yes. I do remember we talked to many of those operators at that point in time, and they really didn't buy into it after all, in this mobile health idea. And with hindsight, I'm saying, you know, that's how they missed a good opportunity, because what mobile operators today are, and of course, anyone in the mobile world will challenge what I say now, but, you know, they are more or less a provider of infrastructure, of bit pipe, of data,
yes.
We
had this discussion
of the data
with the
thing.
Orange speaker 2 weeks
Yeah.
ago.
And they actually missed to become a kind of a service provider, sort of a value-added service provider. Healthcare was just one example. There are other industry sectors. They didn't do it, and that's how it turned out. So, you know, you could say with hindsight, they missed the train to some extent. And, you know, funny enough, I had these discussions with some pharma companies today saying, you know, what do you want to be in 10 years' time, in 15 years' time? Do you want to just be the supplier of a particular drug? End of story. Right. And the other guys on the block are providing really the patient services. They are looking for the patients. They are taking care of the patient journeys and supporting the patients. Or do you also want to be a part of that game board? Yeah.
That's a fascinating
yeah, so that's where the comparison is. And, you know, and I think that the pharma companies or life sciences today have the chance to actually go that way. You know, let's see whether they take it or whether they don't take it. Still open.
Yeah, you're right. Molecule provider or just
absolutely
provider as the provider of versus really a full
absolutely.
Let's see if they're ready and
absolutely.
Yeah.
Okay, guys.
Looking forward to learn from Germany. Yes.
Learn from Germany is a good point. That's how I wanted to start a presentation. Can you learn from Germany? That's the big question.
Yeah. Go ahead.
Sorry. I want to talk today on DiGA, digitale Gesundheitsapplikation, or digital health applications in Germany, and you know, try to give you a little bit of insight on what it means, how it works, how you can get registered as an official digital health application in the system, where we are today with it after, I don't know, 3.5 years. What are the learnings? What, you know, is going well? What needs to be changed, perhaps? And also shed a little bit light on, you know, what other countries are doing, like France, not Switzerland. They do not anything on.
Or digital health.
That's a good point of discussion. We can have that later on.
We'll talk later.
But, you know, DiGA as such was copied by France. It was copied by Belgium, funny enough. So we will shed a little bit of light onto how they are doing it, because they are very similar to what was started in Germany. Okay, digitalization in Germany. Can we learn from it? DiGA in Germany, more than a flash in the pan with a question mark. That comes down to the situation of digitalization in Germany. Whenever I give this talk to an audience, a non-German audience, you know, people think, oh, Germany, yeah, cool. Always innovative, always at the forefront, highly technology, you know, driven sort of thing. And then as we go through it, you know, I see this astonishment on the faces of people, you know, saying, you know, it's not the case. Why? And it is a difficult story. Digital and Germany is a difficult story. And not only in the healthcare sector, but also in other sectors like education or public administration, you name it. And the fact is that we in Germany are trading a little bit behind as far as digital is concerned in all areas. As I said, the question is why? And I try to
move on that.
Oh, that one.
Maybe like
oh, that maybe like that, yeah.
Oh.
Good morning, come in. My opinion on why we are trailing behind is that there has never been really a convincing backing from the political side as far as digitalization is concerned. And that really makes a difference to other countries. I illustrated that, there's no Germans in the room again, so I'm safe. I took the quote, which is a famous quote by now, from the ex-chancellor Angela Merkel back from 2013, when in an interview, she was delivering that statement, so some guy asked her, you know, what about internet and digitalization in your country? And she said, the internet is new territory for all of us in 2013. And that is kind of that shows the situation, which kind of it is improving, but it was for a long time. It was like this. Politics never understood digitalization, never had really the ambition to drive it. And I was talking to one of the managers of Sundhed. Sundhed is the digital health portal in Denmark.
Yes.
In Denmark, that works very well. So I asked this guy, you know, hey, have you any idea why it's working so well in your country, digital healthcare, and not in Germany? And he was saying, well, I guess the reason is that we were able to create trust in the population, in the citizens. They trust us, they trust that the information is safe and secure, and they trust in that there are benefits from using digital tools. And that is a fundamentally different situation from Germany. Germany, we're talking about data safety and data security, and we're talking about how harmful it can be and how, you know, how the things can be hacked and how data gets lost. And, you know, that, unfortunately, that is the kind of discussion we led over the last couple of years, which led to kind of a disbelief also in the population and in the profession, by the way. So it's changing, and unfortunately it's changing. But this is, as far as I'm concerned, one of the main reasons why, you know, we have so much difficulties in dealing with digital in all areas.
No,
Yeah, it's for all sectors, because I understand in Germany is the only country, well, not the one advanced country, still using cash all over the place, which is other place, needs to use the internet banking. But I was wondering, it's digital health, but probably it's in all areas, maybe?
It's kind of all areas.
Yeah.
I mean, we are not only cash, we are using credit cards, you know, but
Because that's
it's
so easy.
it's kind of, whenever I go abroad in most countries, like I hop into a taxi and I anticipate that I can pay with a credit card. In Germany, I also have to ask, you know, do you accept a credit card?
Yeah.
So most people actually do, but you cannot be sure of it.
Yeah.
So, you know, again, you know, it's kind of, as I said, it's a little bit in all areas of society and administration. So there's a lot to catch up, actually. But as I said again, you know, I think we're on the way there, but unfortunately we lost a couple of years.
I just want to jump in because I've been to many of the German company from the company of university
Mhm.
from the Munich actually area. They're the whole Silicon Valley area, I forgot the name. They go to New York in the German consulate. They presented all the smart cities, everything. New York smart city, all this mobile box in phone, actually sponsored by Germany. Funny enough, you just say that. They actually, every, doesn't matter, homeless, whatever you can plug in, charge, get all your information there.
Yeah.
The boxes in New York City. That's already but there 6 years ago.
Yeah, it's not about
It's the German sponsored.
yeah, it's not about that we don't have the technology in Germany. It's about using it.
Yeah.
You know, the
Okay.
like the Chinese have these super high-speed trains which were developed in Germany, and you know, they use it.
Okay.
You know, the Germans don't use it for whatever reason, you know.
Okay.
So it's not about it's not about
it's
it's not about technology.
Okay, thanks.
Okay, so that was a situation, and then all of a sudden DiGA came, and that was like, wow. Because like for the first time, the government and the health administration, they were really with courage pushing something forward which was not existing anywhere else, you know, at that time. So we were saying, wow, yeah, this is really daring, and this is cool. So
Can you tell us if it was one person or it's a group of people who were young?
no, it was the then Minister of Health who said, you know, we have to do something
Okay,
in terms of digitalization. So, you know, we're just going to do it.
okay. So it's a
And
charismatic person taking-
yeah, and that is a very, you know, and that was very well contested at that point in time, because usually Germans say, well, if you do it, you know, you have to prove it for 10 years, and then, you know, you have to have the evidence data and so on, so on, so on. But you know, they just did it, and that was good. And that was really good. And
Before COVID.
that was before
Yeah,
COVID.
exactly.
So that was in September I think it passed in September, October 2020. So what the government said is digital health applications can be, they need to be certified. I will show you how that works. But if they are certified, they can be prescribed by doctors and they can be reimbursed by the public health insurance scheme in Germany. This is important because 90% of Germans are under their public health, schemes. 10% are private. But just to give you an idea, I mean, that is that the majority of the citizens all of a sudden had the possibility to go to the doctor and say, in theory, I have this condition. Is there a digital app for it? And you can prescribe it, and I can use it, and the insurance will reimburse it. So that was a major thing. It was really a major thing. By now we have, and that was March 2024, we have over 60 digital health applications which are registered and which are prescribable and reimbursable. That is changing rapidly. So if you go to the directory, then it's probably now 63 or 64, I don't know. But that changes. So we had a slow start, but more and more are coming. There are challenges. I will come back to these challenges later on. That, as I said, digital health literacy is low. So there's still a large number of doctors on the one side who say, I don't know about this digital thing, and I'm not interested because, I don't know how it works.
Yes.
And on the other side, there are patients who say, I'm not informed that this thing exists, So this is digital health literacy, and this comes down to, here. Unfortunately, I only have it in German. The guy was saying, my doctor has prescribed an app, and 1 in the morning, 1 in the evening. So, that's a little, that's a little bit, that there has to be, there's still a few things to be done on the doctor and on the patient side to really understand it. And as we are in Germany, there is criticism on DiGA coming from the doctors and from the payers, from the health insurers, on the pricing, on the adherence of people using it. Again, I will come back to that in a minute. But that's what happened in 2020. All of a sudden this thing was there, which was good.
Just say
Yeah.
that, because now you say 62 apps, and when it started and when I was giving some keynotes somewhere, I remember just when it just started and it was 12 or 17 in the database. So look at the progress. And it was 2021, I think, March 2021, I was giving the talk. I analyzed all applications one after the other, and I classify them, and I was giving this information because I was looking into, are there wearables, what kind of interactive design is there, how long you are supposed to use the app, what's the volume of the intervention, and some of them are very specific, 12, 16 weeks, and some of them seems to be that for longer. Migraine or obesity was.
I will come back to that.
It was, okay, so you have this information.
I do have this information. So again, one thing on the general digital initiatives in Germany, there are since then a number of digital initiatives by the legislator which have been passed. The most important are DiGA, obviously, which we will talk about today, but there's also digital health, I call DiGA, Digitales Gesundheitsgesetz, if I remember well. So, and there are others, digital initiatives targeting the hospitals, targeting the usage of patient data, for example. So as I said, there's a lot going on in Germany to try to catch up. All these initiatives target at, getting digital health into the healthcare system, so increasing the acceptance and the usage of digital health. Some areas have been touched by these initiatives, like we have a legal and regulatory basis, much better than we had before for using digital tools. The reimbursement is there for some things. And of course, the access to digital tools is to some extent also there. There are still some areas which we need to do, which we need to work on, and that is digital literacy and trust, as I was mentioning in the beginning, and also the integrated care and health data exchange is missing. So there are these structural deficits. Germany still works in silos. There's the ambulance sector, there's the hospital sector, there's the home care sector. There's not much exchange and not much integration going on. So that needs to be changed. Digital literacy, I just mentioned. And funny enough, access to digital tools is a function of social status. When COVID came, there was a good deal of analysis being done on the usage of telemedicine, for example, and everyone's saying, oh, usage of telemedicine is going up. But if you look closer to the data, you will realize that those people using telemedicine were not like the average worker on the street, but the academics, the people who are well off. So you have this social problem in using digital tools, and again, that is a challenge. You have to kind of think about how to involve all parts of the population, not only those people who are your academics or are well off.
Internet access, because if during the COVID there's many cases happening, is not accepting these things, rather divine between the suddenly they realize where the gap of people do not have a proper internet access or the mobile phone for the people less educated or less income there. That's made a change during the COVID. They jump into that.
Yeah.
So it's probably also the basics because of that, right?
Yeah, that's right. So, but that's could be the topic of another lecture. Yeah. So going back to DiGA now is, why did what are the objectives of the government at that point in time, saying yes, we want to do that bold move into digital health applications? Well, they said, of course, we want to improve therapy. We want to, better manage patients, better monitor the diseases and the progression, everything, and also ease the symptoms. Provide a little bit of better quality of life for the patients. Then personalized and preventive care, as you can personalize digital tools and services, that move is desirable. Motivate patients to adopt, to be more active and self-determined. They have their own tools in hand, so they can kind of manage their own health in an active way. So that was also very important for the administration at that point in time. Resource problems in healthcare in Germany. We have resource problems, especially in the rural areas, not so much in the cities, but in the rural areas. For example, when you want a meeting with a psychiatrist or a mental, somebody who helps people on a mental level or mental diseases, you sometimes need to wait for, I don't know, half a year. So people said, well, if we had an application to bridge the gap between their waiting time, that helps people. So that was the resource issue. And of course, then, they said, with making things reimbursable and usable by everybody, we push digital into the healthcare system. So, these were the most prominent objectives at that point in time. So 62 apps. This is, by the way, if you go there, you have the official listing of all the apps. 25, as I put it there, have a provisional listing. I will come back to that in a minute, what that means. And 31 are permanently listed. So of the 62, you see a little bit of the breakdown there of diseases. So there is bones, joints, and knees, and back pain, and everything. Then the whole area of depression, anxiety, mental has big stake in it. Diabetes is there, of course, and pain. And then it goes down a little bit and is distributed on various kinds of diseases and disease areas. One has to say that you can only get a listing if you address a very specific disease. So you cannot just say, I'm having a digital app for improving lifestyle or making people happier. That doesn't work. You have to say, I am addressing insomnia. I am addressing depression. And you have to prove the case for that particular disease. So that's one very important thing. There is no prevention app in there, which is kind of a pity, but that's the case. They don't reimburse any prevention apps at the moment. So this is where we are.
So we analyzed a bit, and we've seen that the provider, like similar logo, was for 4 different apps. That's what you were saying. They had some generic module, and they adapted to specific disease area, and then the code changes.
Yes, you can say, I to construct an app for anxiety.
Yeah.
And then, but then, you know, you needed to adapt. You can say, okay, I look to oncology, for example. People who suffer from cancer, they have depression, anxiety problems. So you do your study in an oncology area with your platform. You might do another study in the area of COPD.
Yeah.
So you have to prove the case in a very specific disease franchise or disease area.
That's also additional thing which I analyzed, and I was showing here just quickly how many of them have some wearable component of the shelf or but no, it was off the shelf, and some of them they had a WeThings.
Yeah.
So there was a Best City, I think,
Yeah.
and they had a wearable and they had a connected scale as a part of the app. And then there was one or two for phobia, anxiety with VR component, virtual reality, where there was exposure, right? Like desensitization service, like part of the service, but not that many, huh?
Is that possible also, just like today, I was in one course on Monday, talk about all these AI tools. So what the future of the AI tool actually is not a new AI tool, rather it's an integration. So I wondered from the DiGA perspective, since you already have all the tools, you just said, many of them actually is individually, but they are interactions. So when you have one case, you may link to the other. So you need to require some specialties, understand the global picture, and then to, or at least understand the medical side. I'm not a medical person, to have really find the integration there. So I assume that's probably the future. And also the prevention of to preventing you for this one, there's other.
Very good comment.
Right?
Very good comment.
So,
Yeah, that's exactly one of the downsides of DiGA. They are not looking to the therapy pathway in a holistic way. You will see that later on. The Belgians are doing that. One criteria in Belgium to get listed and reimbursed is how well it does integrate into patient journeys and patient pathways. That is cool, because that's the way you would have to go. And an app shouldn't be used as a standalone thing. That's one of the big problems here.
Thank you.
How does it work, this fast track approval process? And for German terms, it's really fast, I tell you. It all starts with the medical product certification. That comes down to the European Medical Device Regulation, the MDR. The MDR has different classes going from 1 to 3. 1 is non-invasive, low risk. 3 is highly invasive, high risk. Like 1, you have, for example, a patient diary, you just record data. That is not invasive, that's not very much high risk. 3 is a defibrillator, for example. Invasive, you know, life critical, really. So in Germany, you can only get certified as a DiGA if you are class 1 and 2A. That's also different in other countries, France and Belgium. Probably the government said everything which is beyond 2A is too risky to go through a fast track. It would need more validation. So that's why they stopped at 2A. It's probably going to change to 2B. Probably, I say, it's not sure, but next year it's probably also going to be to 2B. At the moment, it's only class 1 and 2A, right?
1, 2, B. Sorry.
1, 2A,
Yeah, was that
2B, and 3.
Was it called to define a class 1?
B.
Is it classification based on here?
The classification is an MDR classification. It has nothing to do with DiGA as such.
Okay.
It's the classification. It classifies you as a medical product in different risk classes.
Oh, okay. The risk
right?
classes.
It basically comes down to risk. So okay, you build your app. You had it certified as a medical product or medical device under MDR. Let's suppose class 2A. What you then do is you submit that dossier to the Federal Agency for Drugs and Medical Products, the BfArM, in Germany, and you apply for a listing as a DiGA. And usually then the agency decides within 3 months on your request, which is really, usually they do it within 3 months. So they're really fast in terms of, you know, other regulatory processes. So the basic requirements as they are defined in the MDR are security, quality, functionality. So your app has to be secure, it has to work, and it has to function, and the data, it has to, you know, work according to quality standards. That's what you get out of your MDR. Additionally, now what the German Agency for Drugs and Medical Product is demanding are you have to prove positive effects on quality of care. So what does that mean? Come back to that in a minute, but essentially you have to have a positive effect on the therapy, on the clinical therapy, or the clinical outcomes, or on the processes and treatment structures, or on the patient journey. Either one of that. But you have to prove that in a study. If you don't have it, you get the famous provisional listing, and that is valid for 12 months. So the regulator says, okay, you don't have it. You have 12 months to show it to us. You have 12 months to do a study, otherwise you will be kicked out. And after 12 months, you have to submit your study results. If they are okay, then you are listed as a permanent digital health application, reimbursable and prescribable. You can be reimbursed and be prescribed with a provisional listing as well, by the way, but you have these 12 months. Price negotiations, then that's a challenging thing. Basically, for the first 12 months, as a producer of a digital app, you have, within certain boundaries, of course, the right to define your own price. See that later on, you know, price ranges, that's so large at the moment. So that's for the first 12 months. Then, if you are listed permanently, you have to negotiate with the roof organization of the German health insurance companies, and that is usually they usually dictate you the price, and that can be a challenge, because we had like 2 or 3 DiGA application and providers who dropped out because they couldn't cope with the price decrease. So they said, you know, this doesn't support our business model. We went into bankruptcy more or less, so they went out. So you have to be careful to not overshoot it, and you know, if in your business case calculation, you have to take that into account, that the price might drop. Okay.
You still have to provide the app and solution.
You still have to
update services.
You still have to provide everything. Yeah.
Servers and
You still have to provide everything. Yeah. Yeah.
Operating system updates and whatever. Yeah.
Yeah, we have, I think the most, we will see it later on. The most expensive app is, I think, 2,000 euros for a quarter for 3 months, which is an app on.
Okay, you're going to show us.
On, yeah, but anyway, that is going to disappear. But just to give you an example, you know, it's, as an app provider, you really have to think about this, because otherwise you run into problems. Yeah. So that's how the whole process works. And of course, you know, the challenges there are the documentation you need for your MDR classification, the data you need to create for the quality of care for the German system, and the price limit set after the 12 months. So, but it's a straightforward process, and, you know, fairly simple, I have to say, for, you know, compared to other registration for drugs or whatever, it's fairly simple and fast. Again, a short view to what these clinical benefits mean, and you know, how you can, you know, how they are defined. So this is what you have to prove if you need to prove your clinical benefit or your benefit. It's the medical value or the effects on the treatment structures and process. Either one, you can choose. So medical value and benefits. What are these? The condition as such, the duration of the health condition, prolongation of survival, improvement of quality of life. You know, this is usually what they mean. Funny enough, there are no demands on proving health economy, in contrast to others in other countries. Like in England, you have, for example, you have a catalog of apps which are treated in a different way, but anyway, there's a strong focus on health economy. You have to prove the health economy case, but not so in Germany, not so in Germany. On the structures and processes side, there is care coordination, patient adherence, access to treatment, patient safety, health competence of people, compliance to treatment standards, and coping with health conditions in daily life. So these are effects that, you know, have an effect on the treatment structure, on the treatment processes. And if you can prove, you know, benefits in that case, that's fine as well. So you can choose either one. Again, you know, this has to be an approval is specific to a particular disease or a patient group. There's an ICD coding, which, you know, you can use, saying, you know, an ICD coding for a cardiovascular disease or oncology. Every disease condition has an ICD coding. This is WHO standard. So you have to say, okay, ICD coding XYZ. Alternatively, you can use SNOMED, which is another, you know, codification, or alpha IDSE, which is a numeric thing associated with an ICD code. But anyway, you have to be very specific in terms of disease you are addressing, that it complies with these international standards. Right, so if you want to get listed and the agency turns it around, so you have to prove the, you know, the benefit case, you know, this is what you would have to prove. And usually you can do a trial, not as sophisticated as a drug trial, for example, but you still have to sort of do a randomized trial. You can also say, you can also include meta-analysis. You can use existing studies, but you have to produce some solid study results. Usually, people do that around 100 to 300 participants, something like that. So there's a chance that you can actually do it in a year. It's not so super sophisticated as a drug study, which takes years and years and years. That would defeat the purpose. Which is, by the way, also a point of criticism from the doctors. They say, wow, this is too fast, this is too shallow. But anyway.
Tested with the users is basically both sides, right? The doctors, nurses, and
no patients. Only patients, yeah. Usually, like you equip a population of patients with the app, and the other one goes with the standard therapy without the app. Straightforward. No doctors involved.
And later on, they need to prepare for they are not trained and they need to prescribe it. That's why there is a hesitation.
Because they're not basically using it. They really don't know, but they are experts, right? So I personally believe that. So no, I'm just curious. Just good.
Okay, guys, this was like, you know, that part which you know, shows you what DiGA is, where does it come from, how does it work. If that's clear, you know, I will go to more usage related things. Okay, that's what the fun.
Maybe you answer the question later. As a service provider who would imagine that I would say there's an app and am I later on responsible for like promoting, or it's?
Well, of course.
Okay. It's not that it gets into the database and it magically appears on everybody's.
That they want to.
You are, of course.
Okay.
You are, of course.
So I'm going to give pens to the doctors, you know, like the pharma. I'll give them little.
I would perhaps.
My app, please.
I would perhaps. There are other ways, you know.
Okay. I'm just laughing. The pens and even buying coffee.
But you're right. I mean, HCP engagement, doctor engagement is a subject for anybody who wants to work with a digital health application or DiGA, because, as you say, being in the directory is nice, but you know, it doesn't mean that the patients know it or the doctors know it. So.
Exactly.
Okay, usage. That's where the really fun part starts.
Okay.
Let's look at the prescription process. Now, that is different to a standard prescription process of a standard drug in Germany. If you go to a doctor in Germany and say, you know, he prescribes you a drug, he issues you a prescription, either on a little piece of paper, which you then take to your next pharmacy and you are handed out the drug. Really easy. Or since 3 or 4 months, you can also utilize an e-prescription. I know, I use it. It works really also flawlessly. The prescription is on your health insurance card, and you go with your health insurance card to the pharmacy, and they read it out and give you the drug. So you know, very easy. This is different. This is different. So how it works is the doctor, if he knows it or she knows it, prescribes you the DiGA. He issues the prescription. You cannot go to a pharmacy now. That would be too easy. Or you cannot just start using it. It would be too easy. So what you have to do as a patient is you have to send that prescription to your health insurer. And that's already the first challenge for a patient. Then the health insurer checks it and verifies it. And if it's okay for the health insurer, he sends a code back to you. Yes. You then take that code, you load your app down, for example, for the DiGA, and you put in your code you receive from the health insurer, and then you can start using your DiGA, your digital health application. So by looking at it, you know, you can say, there might be some breakpoints in there. Also given the health literacy of the average German citizen. So the barriers, first of all, as you rightly said, a lot of doctors of healthcare providers are not aware that these DiGAs exist, or they don't want to know it. So that's the first, you know, critical thing. Then the patients say, you know, I have this, you know, prescription now, you know, and heck, where do I send it to with my health insurer? Do I have the contact details? Who is responsible, and so on? So, you know, that's the second challenge. Patients need to send it to the health insurer. Then eventually they will receive a code. If it's fairly quickly, that's fine. But still, you know, if it takes 2 or 3 weeks, then the code will arrive. The patient says, did I send that code? What's it for? You know, well, maybe I do it later. You know, that's how it works. And there are a lot of, there are actually, you know, quite a number of codes which are never, you know, used really. So, and in the end, then I will show you some figures later on. There's a relatively large number of patients who are not adherent. Usually, a prescription for a digital health app is for 3 months, right? So that's what the health insurance pays, and the provider gets. There are quite a number of people who actually stop using the digital health applications after 2 weeks, after 1 month or so. Which is bad for the patient and which is bad for the insurer because they pay for nothing, which is a big point of criticism. So you see, these are the barriers, as I call it, or the breakpoints in that process, which is not an easy process and which is kind of a challenge, you know, in the whole thing. So the question is, you know, what can you do to actually help the doctors and the patients to, you know, go through that process in a smoother way. And this is where, you know, I'm working with a couple of people at the moment on designing a service platform or service offering that we can offer to digital health providers, digital health app providers, to support that process. And what we came up with is that solution here, which is a modular solution that, you know, sort of addresses the different barriers. So what we are saying is there should be a basic support where you provide a list of the contact persons, of the addresses and the contact details of those people inside health insurance companies who are dealing with it, so that the patient says, okay, you know, this is a list, you know, this is the email address or this is the postal address or whatever. And there are still, I think, almost 200 health insurers in Germany. So you have to, large and small ones. So you really have to help them there and say, you know, you have to collect all those data and say, you know, these are the contact details. What you can also do in that.
90% of people have a public health.
Yes, yeah, of course. There's this endless debate in Germany where and the difference between those, I don't know, 170, 180 health insurers is not big. It's not big because, you know, their service level. Their service level is regulated by law. So I cannot just open up a health insurance and say, I only, I provide half of the tariff of usual, that is not doable, or I provide this and this service. It's not doable. So the differences between the offerings of the health insurers are marginal, really. And of course, you can say, why do you need this high number of health insurers in Germany? And you're right, it doesn't make sense. It would make sense to have one national health insurance, as it is the case, for example, in Switzerland, and that is the end of story. But yeah, but
Actually, before you go into barriers, I just, back to our earlier stage, you have DiGA, you get only patient, you don't get the doctors. So today, when the doctor give me drugs, they actually, it's too expensive for me for insured, that's why we don't go back. We think that will help, but with digital, you don't have to go back to doctor. Doctor should be the way to access that DiGA. That means there's feedback. So that means if I don't use in that DiGA, that means the data not feedback for the any improvement. That's the same as insurance. So wouldn't that be the basics to know the patient is not using it as that's better? And also for the doctors to have the feedback to see 2 weeks, 3 weeks, what is the progress of that? Otherwise, it is useless to have it.
Yeah, that's the
So
yeah,
that
that's
be the foundation, because otherwise, what am doctor prescribing for? Because the drug or any other ones, there is a feedback, because I'm going back to my doctor, tell me, say, this drug didn't help me, I'm still in pain. And the doctor had to find a different way to do that. If I'm not in pain, I don't come back, it means because
Of
of
course.
the result of testing.
Of course.
So I just say to start back to earlier, why doctor did not part of the whole development and usage, all that should be 2 ways, no?
There is no feedback, there's no such feedback mechanism in the German healthcare systems, neither for a normal drug nor for a digital drug. What we have here is, and that is like the most sophisticated module here. What we can do is saying we give that feedback to the healthcare provider, to the digital app provider, and say, look, these people are not using your app. That is something we can do, and to motivate those people then to send them, to get in contact with us and say, we've seen you're not using your app. Why is that? Can we change that? That is the adherence problem. How do we address that adherence
Also
problem?
for the insurance too, because if they pay the insurance and they should have access as well to see what it's a feedback, right? And then because the reason is that we're still thinking, our mind thinking the traditional drug, as what you just say, it takes so long to test the results, so we know the result way ahead of so years. With the digital one, it's so fast, like a few months. And if you don't have the feedback, nobody knows.
I know, yeah, perfectly well.
I don't know, you say you know it, because you're consulting, I was thinking, there should be the thinking.
Yeah.
Sorry.
Yeah, but it's
Sorry,
as I said, there is no such feedback mechanism. Even
Yeah.
for if you go into a German doctor and said, I'm prescribing, I get prescribed a classical one is a drug for high blood pressure, hypertension. Many people, the adherence to a hypertension drug is disastrous. Like, I don't know, 60%, 50% of people just stop taking it because they say, I'm not feeling anything, why should I take it? But there's no feedback mechanism. The doctor doesn't know that the person is not taking his or her drug. So that's a problem of the patient journey. And again, there's much to do on the patient journey and on the communication inside the patient journey. At the moment, this is not taking place. Yeah.
You just
Yeah.
with myself.
Yeah.
I didn't take it for a long time, but then my doctor said, you need to do that. Then we go back and do the regular checkup, like every month or two. And then he said, well, come in. Well, of course, because there's some money involved, right? It's expensive.
If the patient is doing the regular checkup, that's fine. Then
they call me to go in. Yeah.
Doesn't happen all the time.
Yeah.
There are doctors that just say, no, I just prescribe, and if it's a good doctor, I mean, you need to refill your prescription at a point in time. If it's a good doctor, then he asks, before I issue a new prescription, are you taking your medication and how is it going? And if it's, you could do actually saying, that the patient hasn't refilled the prescription for half a year now, what's going on? But I don't think there are many. but I don't think there are many who are doing it, actually. Okay, but anyway, you know, this is the kind of support that we envisage to actually offer to DiGA providers, coming from that basic support, as I said, to list the health insurance contacts, maybe also to provide an upload function for the patient. Like instead of sending an email and or posting it, you just say, you have an upload function here, dear patient, just load it up and put the address of the health insurer in it, and then you send off your prescription. And you could also, of course, integrate that upload function into a supplier's website, which would make it very easy. Then the next level would be that we could say, okay, it's not you, patient, who sends that to the health insurer and takes care that, you know, that if you really arrived and that you get your feedback. We do that as a service organization, or either the app developer or the app provider does it. Usually he doesn't do it because that costs money. So, you know, you can say, you know, I go over a service organization, a third-party organization who has that infrastructure. So the patient sends that to that service organization. The service organization takes care of the prescription, sends it to the health insurer, make sure the health insurer replies, make sure that the patient gets the codes. And, you know, sort of that code acquisition process is then managed by a third party, and the patient doesn't have to take care of it. The third module is then really that on top of that, you offer the patient support on adherence, what you just said. You regularly call them through a contact center, or you send them a message or saying, look, hey, are you doing well with the app? You know, is everything going all right? Something that we can do for you, is that something you don't understand, or whatever, you know, just, you know, talking to the patient, trying to get the feedback from the patient, motivate the patient. So you have, in that last step, you have kind of a hybrid care model where you say, this is a digital tool, but, you know, this is a patient support that comes with it. At the moment, this is in Germany not the case. But, you know, as most probably we'll have a change in the law saying that full reimbursement will only take place when people use it for the 3 months, which I think will come next year. It will come. Then all the suppliers have a problem. So that's where they need to go. They need to think about how we're going to talk to our users of DiGAs and to make them adherent, using that for the full 3 months. Again, the government will say, not my problem, your problem. So I do hope that, because that costs money, of course, I do hope that this will also be reflected in the reimbursement. I do not know, but, you know, I'm almost certain that this will come where the government will say you only get a full reimbursement when people really use it until the very end, and not stop after 4 weeks or 6 weeks.
It's the name we are missing. Patient.
How do I?
There is a black.
Move that cursor. I think that's what I was trying to do. Is it possible to move the cursor back?
Can you make
Oh.
it louder?
No. Go back to, oh,
Yeah.
we are online, we're here, okay. We are trying to move this little thing here. Gosh,
That's weird.
how do I not know my own laptop? Okay.
That's better.
Concierge,
Yes.
what a
concierge.
nice name.
It's a rather post app care services.
Yeah, it's patient.
Which is, we can talk later. I just wanted.
The thing is,
the
yeah,
app, it's on your phone or whatever, that you could easily feedback, like the way app actually trigger right back, as long as I'm accessing to it, I allow you access, that means the data should be with the feedback.
Mhm.
So I have to go back to the personally calling to the, except I just don't know what.
You're a solution, Maria.
Yes, you have to be, yeah.
The
The thing is, you have to be a little bit careful with personal data. You cannot just say,
Sure.
Mrs. Smith hasn't used her app for the last 10 days. Now I'm going to send this name to the health insurer or to the provider. That is deadly. So you have to be a little bit careful as to how to approach these people on an individual basis. You cannot just, you know, give their details away. Yeah, but there are ways to, you know, use this in an anonymized way, or, you know, contacting people in a yeah.
There are ways.
Yeah, and
So that's why you are introducing a separate entity which will have like legal rights to be in between.
Yeah,
I love like yet another stockholder. Yes.
yeah, you have to be very careful. There is an initiative in Germany on the usage of patient data for various purposes, like for research and so on, not for commercial purposes. So it's easing a little bit down on the usage of anonymized patient data, but you still have to be very careful what you do with and how you approach patients. And you cannot just, you know, give away a patient's name or his usage behavior to any other entity. You cannot do that. Yeah, so that is again limiting your ability to, you know, interact in that patient journey.
Yeah. Yeah. Okay.
Yeah.
No, just you're right. That's okay.
It just
Okay.
works.
I had a look at what are the reasons actually that people start quitting usage of a DiGA, or stop using the DiGA prematurely. And again, you know, this is in German, unfortunately, but translated. It is a study that has been done by a large public health insurer, the Barmer, in 2024. And they asked people, why do you quit using, or why did you stop using your DiGA? Then they say the first one is, I've lost interest. The other one is, it didn't fulfill my expectation. It was marked with a star. I had technical problems. I didn't understand the content. The content didn't fit my symptoms, and the handling was too complicated. All of these things which are marked with a star are addressable by adherence management. So if that is that last module I was mentioning, if you talk to the patient, if you ask the patient, if you support the patient, then you have a chance actually to minimize that. If there are problems, if there are technical problems with the handling, problems, expectation management you can do, and motivational management you can do. So there are actually factors you can address with this adherence program, which we are thinking about.
Is there any, in relation to that, is there any age generation barrier in between? Because I think everybody's signals is wrong founded for them is very easy.
That is a very good, there's a very good
question. If you have out on that.
That's a very good question. I don't have data on that actually.
Okay,
Yeah.
well, I wonder
Yeah.
if those ones, the
Yeah.
people who signed up to do that or prescribed it, what is
Yeah.
the age generation?
I don't know.
that's-
Yeah.
Yeah, okay.
I don't know.
No,
I
no,
don't
just
Yeah.
curious to know
Yeah.
that.
So the thing with this data is also that it varies from indication to indication. I was somebody who is in pain, for example, he's probably more motivated to use an app to ease his pain than
That's true.
any other indication, for example. So, you know, but it gives you an indication on, you know, what people are struggling with and, you know, where you could possibly help them. Healthcare professionals, doctors. There has been a survey performed by Berlin's Charité Institute of Medical Informatics, 2022, but, you know, it gives, again, an impression on what's going on, because you asked, you know, what do I have to do as a provider of a DiGA in terms of communication, in terms of involving patients and doctors, and, you know, this sheds some light onto the situation there. When they asked a little bit over 1,000 persons back in 2022, average age was 47. And they found out that only 22% were aware of that the DiGA exists. So on the patient side, you can say there was not so much awareness. Now this might have changed since 2022, but I doubt whether, you know, the majority of the population knows what a digital application is. and that it can be prescribed and reimbursed. Maybe they know, okay, there are digital applications, but they don't know about that they are prescribable and reimbursable. Then the vast minority of patients, 15%, were informed by the doctors of DiGAs and of the existence of digital health applications. So, and again, that might have a little bit increased, but shows that also on the doctor side, there is either not much knowledge, awareness, or not much motivation to go to a patient and say, look, by the way, there is a DiGA that may help you to in your therapy and may help you to ease symptoms or may help you in your daily life.
Stop, a question. For the healthcare professionals, do they get paid the same way in using DiGA or traditional? You know how I don't know in German.
They get paid as for not.
It's the same amount, same rate.
I have to look that up again, if it's the same rate. If
because there's the incentive difference, right? So if doctors see me for, I normally see me 5 minutes, I know, in New York, and then they get paid by 15 minutes.
No, I mean the doctor gets paid for the consultation.
Yeah.
And gets paid for the prescription usually.
Yeah, that's that. I just wondered that.
Yeah. So, in a nutshell, what I want to say here is that, of course, the healthcare professionals are key. The doctors are key in bringing digital health applications and DiGAs to patients. So, for a DiGA provider, you could say, I have to work on that. I have to think about how to engage the HCPs in a meaningful way, maybe not by putting pens on the table, but maybe through other ways. So this is, what is called that maybe a push effect. So you talk to the HCPs and you try to create sort of a push of that into the market and to your patients. You can also say, I'm working on the pull side. I'm informing patients to go to their doctors and ask. But all of this costs, of course, money, and this is kind of difficult to do for most of the DiGA providers. So especially the pull side. You cannot talk to X number of patients. You can come around and say, whom do I work with? Do I work with patient organizations? Do I work with these multipliers? You can do that, but you certainly have to work with your doctors, with your HCPs. So again, that's a little bit also the challenge for the DiGA provider. You cannot just say, I have a DiGA which is listed and it's sitting there. You have to do something in terms of making it known to HCPs, maybe also to patients. So also and of course supporting the patient that uses it in terms of the process, in terms of adherence. So these are some of the challenges that DiGA providers are faced with. Okay, here are some figures. We have 62, as we already seen. What are the number of DiGA prescriptions? Since the launch, we have 375,000 prescriptions. In the last year, it was 235,000. So you see that we are kind of speeding up. If you look to the public health insurance expenditures of DiGA, it's 68 million, which is still peanuts in terms of the whole healthcare expenditure on drugs in Germany, which is 50 billion, something like that. So put it there. So it's, I don't know, a little bit more than 0.1%, something like that. So, all those people who say, well, they are costly, which they might be, in terms of the total share on the cost burden, it's still peanuts, I would say. The conversion rate of DiGA prescriptions. So that's the famous, do I use the code or do I not use the code? It's a bit difficult to get hold of figures there now, from talking to DiGA providers. this could be depending on the disease indication, 40 to 50%, which is quite a bit. So yeah, that's, you know, as I said, this is really up to disease condition. But if you have a 40% drop-off rate at that point, you know, it's kind of, you know, challenge. There's much better data on the usage of DiGA. You know, usually you get it prescribed for 3 months, for 90 days. 50% of people, 53% of people are using it, and 30% are discontinuing to use it, which is still quite a bit. You know, that is the adherence challenge, which is imminent, really. So, you know, this is where most probably change will come, and, you know, the legislators will say, you know, we're not paying at least the full amount if, you know, we have that large amount of discontinued usage. Again, of course, you could say that adherence is it's not only a problem here, but adherence is a problem in many with traditional drugs in many other disease areas. Hypertension was just one example, and, you know, I'm sure that we have in many other disease areas with traditional drugs, we have the same type of non-adherence, same range of figures. Reimbursement per quarter. So you only reimburse per quarter. It's between 250 and 70, the average reimbursement. However, we have this multiple sclerosis DiGA, which is at 2,000, which is over 2,000 euros per quarter at the moment. So you see that there is a range, but there are not necessarily that, you know, each and every DiGA is in that range. And as we've seen before, that is kind of an important discussion you as a DiGA provider should lead early. You know, what kind of price does my business model hold? I have all liberty, or almost all liberty, in the first 12 months, but what happens afterwards? If I overshoot, you know, I'll have a problem after 12 months is to, you know, keep my business model alive.
This reimbursement, who receives the reimbursement? Patient, the doctor, or the insurance? When you say reimbursement,
it's paid by the National Health Insurance.
Okay.
Yeah, the patient doesn't have to pay anything.
No, not to the patient.
No, to the provider.
Yeah, yeah.
To the app provider.
The app provider.
Yeah.
I see that.
Yeah.
So I guess the multiple sclerosis patients, we can think about, you know, it's not a drug, right? So I actually don't know this. You can click and check. Do you know what exactly this app is doing? It's something lifestyle management and
it's lifestyle management.
Because most likely it's calculated how much improvement in your daily life it's providing.
Yeah.
Multiple sclerosis patients are suffering a lot.
They are suffering a lot. It deals with lifestyle management. It deals with anxiety. It deals with, you know, managing your daily life better.
So it's a physical health, psychological health.
Absolutely.
Some other aspects.
Absolutely.
And then they calculate, okay, so the improvement in the condition is so much, there's so much. It's about like going from quality of life adjusted life years, but to the meaning. Yeah. Somebody made some calculations. Yeah.
It's not, as with all these digital health applications, they are not a substitute for traditional therapy. They should be a supplement to it.
Yeah, supplement, exactly. Exactly.
Yeah.
Thank you.
Okay. If you compare the actual not DiGA one, are they cheaper in some ways? Is less expensive?
The other apps,
between the app and how do I see that? For instance, you say supplement to the physiotherapy, so they tell you this is your exercise there. It's just in addition. So otherwise you don't have anything to use, right? So it's like you go to physiotherapy and you do once a week, but instead of going there 2 weeks, you're actually using the DiGA to remaining to use in the rest of the time. So you only need to see the physiotherapy once, let's say, which is paid by the insurance, and you're using DiGA for the rest of the week, help you do better. That means the insurance actually the overall payment's less. That's the idea, right?
Yeah, you know, it's really. I mean, the overall idea is that with the DiGA, you support the therapy of a patient for example, in terms of his or her daily life situation. You say the patient is able to cope better with a particular disease condition. That might help him, for example, going to the hospital frequently, might save acute episodes, might contribute to him or her leading a normal life, being able to go to work. So these are the things that DiGA plays on. Depending very much on the disease conditions as such. But these, it does not, I think it should not and will not substitute a drug therapy. An MS patient would still have to take his or her own MS drug, but it might, for example, help to reduce the number of acute episodes or prolong the time between acute episodes. Make between those acute episodes, make life easier and better. So this is yeah.
There's no, it's difficult to collect data directly. It's not like replacement kind of data for the.
No, you cannot.
Related,
You cannot substitute.
The whole.
Yeah.
The entire process kind of. Yeah. No, I agree.
The thing is, I mean. And this is where still, I presume, a lot of work needs to be done. You cannot, as far as I'm concerned, you cannot look at a DiGA in an isolated way in a standalone fashion. You would have to observe it in the context of a drug or therapy, a whole therapy regimen. And sometimes, of course, you might say, you know, this takes a long time to have to create data to see, you know, what are the long-term effects on patients having more quality of life. That is difficult to prove in a short term. But, and this is where the chicken and egg is really. But I think, you know, this has to be, this has to be done in a more prominent fashion in the future. See the DiGA as one component of a patient journey or a patient therapy regimen, and see and evaluate its effect within that therapy regimen, that patient journey. But that is again, you know, something that, you know, is probably is not happening at the moment, and is, of course, given the short time, difficult to prove.
That's exactly.
Yeah, and you can always, I mean, that's as I said, it's chicken and egg. You know, there are a lot of people who say, also professionals who say, why is there a reimbursement for a thing which we don't have a full understanding of its effects? You can say so, but then again, should that make you stop? I don't know. If you say, you know, we have problems with, you know, monitoring patients, with taking care of patients, we have small resources, and so on. If you say digital is a tool to overcome that, then, you know, you should have to do it. If you say, well, you know, I want to wait until I have proof, you don't, yeah.
Some people could say, hey, I can find all the different kind of online free people doing TikTok that show you how to do certain type of exercises. Why you are paying that? I personally will not pay very much like that. Then I was just using that one because I know that probably, well, it's free and it's more fun. Second one, because if I do that, because the insurance pay for me, so that's why now. That's the incentive why if I don't use it, I don't care because I didn't pay for it, right? So that's why it's hard to see the long term. You chicken egg thing. It's difficult. Yeah.
Okay. Here we are. Usage and the way it is at the moment. Let's go towards the end. Just, you know, three things to finish off. I also need to show you a little bit on what's going on in France and Belgium, by the way. But at this point, Now, you've seen things now. If you now say, well, that's cool. I want to open up my own company and create a digital health applications and maybe even go for a DiGA, what should I do? And I try to put together some points which you maybe should consider when you plan to do that. I think it's a cool thing. It's fun. I did it myself, but it's kind of also hard work and not easy. Okay, so the first thing you should ask yourself, you have a digital health application. You might even have an MDR certification. You can use it as a medical product. Do I want to go really to the DiGA? Do I want to sort of go that painful way with all the regulations and the boundaries? Or the alternative is you can go to you can conclude an individual contract with a health insurer, with a big health insurer. Then, of course, that contract offers you more freedom because it's an individual contract with a health insurer. So that's always an option you have. It's not automatically a DiGA that you can go for. You can also do go another way. And you can, if you do that, if you convince the health insurer, for example, or any other healthcare provider, you can use that as a go-to-market partner. Then we talked about pricing. You need to really ask yourself the question after this: is my business model strong enough and solid enough to live through that period after the 12 months? Then, of course, it costs you money to create all that data. MDR is already quite a bit of a burden to do. If you, on top of that, need to prove your effects on the quality of care, that is an additional thing you need to do, and that costs money. So you have to take that into account. If you don't have, of course, that thing, you need to invest into quantitative and comparative control studies. As I said, that costs money. Then, if you go to Germany, which part of the healthcare system do I want to play in? Do I want to play in the hospital sector with my app, or do I want to play in the ambulance sector? You have to take that decision, which is also, does your value proposition fit to the target's interests and needs? I was talking to one provider a while ago saying, I have an app which the hospital could monitor a patient that has been discharged from hospital later on. I said, not a good idea in Germany, perhaps, because hospital doesn't have the interest to do so. Because the German hospitals system works in sectors. You get paid from the hospital side, or you can pay from the ambulance side or from the home care side, but not in between. Usually it's very difficult to get something in between the silos. So if you have an app targeting the in-between thing, maybe that's going to come. At the moment, it's difficult. So you have to make up your mind, where do I want to play? Go-to-market partner, market entry facilitator, marketing, business development, communication, all of that. You need to take that into account. Either you do it on your own, or you look for a market entry partner. It costs money. It's not that you just say, I'm going to get listed and it's sitting there, and this is like a self-running thing. It's not the case. So again, you have to plan that in advance and say, how much does it cost? Where do I get the money from? How hard do I have to press my business angels to invest? No.
5 million friends and already around.
Yeah. What will I do to my family and friends? Right. Okay. That's something in general. If from talking to pharmaceutical companies, from talking to life science companies, we have the discussions with life sciences companies. We want to have an app supplementing our traditional drug therapy, and they say, this app has to be solid. What does solid mean? These are 6 points which we hear all the time, and we run into all the time. Say, look, if we want to work with an app, it has to build around a scientific model. For example, cognitive behavioral therapy. It has to be backed by clinical evidence. It has to be approved and certified. It has to be personalized So you need to adapt it. You need to have a certain level of personalization in there and of performance monitoring. It is advisable to cooperate with academics or industry or other app providers to build it in terms of the true sense of co-creation, for example, or collaboration. Inclusive and interactive. Number of features and user interfaces, highly professional user interfaces, depending, of course, the features on the disease condition that you're looking for. What do you actually need to provide value to a patient under that disease conditions? You have to understand what the patient needs and what it wants, he or she wants. And does that reflect my features and functionalities I have? It doesn't make sense to have an app for a particular condition which has features that a patient doesn't need, or you don't have a feature which a patient desperately needs. And then, diabetes is a good example. There are so many apps, so many devices existing, and, people always complaining, okay, I have a monitoring device, I have a diary, I have this and this and this, and they said, come back to me and say, I have 3 or 4 apps that I have to use to manage my disease. Why isn't there one single, application that unites all these features and functionalities? So again, if you want to go down that way, if you want to enter the pleasure dome, that's the way you play. Finishing off before we go to France and Belgium. Digital health applications, you shouldn't use it in a standalone fashion, because that's what we discussed so many times now, because it might not only lead to false results, but there is no real benefit at the end of the day from it. So what I always say is, ideally you have to embed it, and I think that's where the journey will go to in the overall care and therapy regimen. You cannot just, we started using it in Germany in very many instances in a standalone fashion, but that will go away as we move forward. User support in the terms of hybrid care will be integrated, and I think that is going to come in the near future. Otherwise, we can say it's picking up speed. We still need to have to work on the awareness side, on the healthcare professionals. The adherence issue needs to be addressed. So there are a number of things which are put there, which I would say, okay, needs to be adjusted. But I belong to that group of people who say it was worth the start. And, you cannot change things from one day to the other. You cannot say, I have a digital application, I expect that all of my citizens now will, desperately run after digital application, and my doctors will say, wow, it is quite a way to get it into the healthcare system. It's not fully there at the moment. We're just starting, but I think we're on a good way. So I'm an optimist. And for me, the glass is always half full. So I'm not one of the people who say, well, there are so many that are challenges and we should stop using it. Why should we do it? We have issues. I think still worth it. So, that's my positive conclusion from looking at DiGA since it has been launched. And I'm sure that, we will go, DiGA will be a component of the digital solutions in Germany. We talk about e-prescriptions. We have established e-prescriptions after, 15 years of discussion, but it works well. From next year onwards, there will be an electronic patient record in Germany, compulsory for everybody. You have to have really an opt-out. We are talking about telemedicine that is going into the system without the limitations we had so far. So there's a lot going on, and I'm convinced that DiGA is going to be a part of that digital story at the end of the day. That was Germany. France, quickly before. In France, we have, the funny thing is, I think for the first time in history, a digital health thing has been exported to another country. Because the other guy said, wow, this is really cool. We want to do the same thing. So the French and the Belgians started. France, it's called PICAN, DMD, digital medical device, if I remember well. The fast track is called PICAN. So I, made a little bit of a comparison. They're quite similar, as you see. The things which are marked in red are different. So, classes 1 and 2A, they are rather low-risk classes. In Germany, only 2B coming, maybe. In France, they're all classes. Certification required, yes. Reimbursement, yes. Amount of reimbursement after the 12 months is negotiations with insurance. In France, they said max 780 per year. The French said, okay, this is the one-time fee and this is the monthly fee. That's it, max 780 per year. Proof benefits for permanent listing, 12 months. There are central registers in both countries. The proof points are very similar: clinical benefits, structures and process improvements. The compatibility and portability of health data is a concept that is there in the two countries. The electronic patient record from 2025 onwards in Germany, and the INS, French National eHealth ID, and Mon Espace Santé, which is a digital health portal, is also on the horizon. So there is this perspective of integrating the data into other things. That's the process in France. So you have the PICAN, who is the fast track provisional reimbursement, and then the permanent reimbursement, pretty much the same as the German approach. So you apply for a provisional reimbursement first. You get that for 1 year, which is non-renewable, and then you have to supply your proven evidence to the ministry and to the bodies there, which are on the list in that picture, and then you get reimbursement. So pretty similar actually to DiGA. Belgium, the Belgians, they have this pyramid. It has 3 levels, basically 1, 2, and 3, which difference between 3 light and 3 full. I was, say 3 minus and 3 plus. So again, similar to DiGA, you have to have MDR classification to start with. That is the level 1. Then that is something which is particular to the national standards. You have compliance with data protection and interoperability standards. That's level 2. You have to prove that. And you have to present your study concepts for quality of care then at level 3, where you get your provisional approval and your permanent approval in step 3 plus. So again, very similar, although it's a pyramid, it's kind of similar to DiGA. The differences are there that this provisional approval is valid for 3 years and not for 1 year, which is quite a bit of time. All MDR classes are eligible, so not only 1 and 2A as in Germany. Telemedicine and professional solutions are eligible, not so in Germany. Then this health economic or socioeconomic benefits are part of the approval criteria. That's also a difference to France and to Germany. And which I find very interesting, the last point, that the integration into existing digital care pathways is important. That's very clever, because the Belgians, they have, as far as I know, a national patient record. So it doesn't make sense to, say to the DiGA provider, you have to make sure that it's compatible with, that. Digitalization only makes sense at the end of the day if you exchange data and if you standardize data, because otherwise, So this is, again, something which is different in Belgium, which is very foresightful. And I think which will eventually also come in Germany and also in France, as we go more and more towards patient records and digital patient records. Okay.
Okay.
That's as far as I'm concerned. If you have the strong feeling now you should do it, then go for it.
I guess the question for me would be asking you, are you using some of those DiGA apps yourself?
No.
Bravo. Okay. I have another question. Absolutely.
I'm not.
And it's
I don't have any
like-
condition which justifies a prescription. Let's put it like this. I use trial versions and I use digital health applications, or have used them in the past on various, reasons or for various, purposes, but I had never had a DiGA prescription myself.
I was about to ask you, now I'm in front, but anyway.
So the difference is also between other countries. It looks like they're opening for higher risks, right? Imagine like these different devices, but then I presume the evidence before you even start being prescribed, it's harder. You need to have more evidence.
Yeah, it's also it's the balance between, making it easy for digital application providers or DiGA providers, making it easy and quick,
Yeah, yeah,
and covering the risk.
yes.
So
exactly.
if you make it too difficult and too long, all the startups will say, well, that's
Of
not,
course, you have to pay that, but
Yeah.
it's another option.
So, it's always that trade-off, which you have to be careful. And of course, you shouldn't put patients at risk with whatever you do, digital-wise. Yeah.
Okay, and then the question related is like you have this 12 months or 3 years or whatever, it's this provisional. Can you use the patients who are being prescribed the app as a cohort for which you collect the data? By default, do you collect data for them? And if
yeah.
you-
I think so, yes.
Oh, yes.
I think so,
Okay,
yeah.
Okay, so it's a part of evidence.
You should be, yeah.
It should be, right?
Should be, yeah.
Because
I
then you'll
don't,
be like,
yeah, I think so.
you need additional investment to have a cohort inside. While the people who are using it maybe not even benefiting.
I think so, yeah. I cannot think of any reason why you shouldn't.
I mean, it's like a real world
Yeah.
evidence in this
Yeah.
sense, yes, so
Real world evidence.
you get this, you're smiling, but it's real world evidence.
Yeah, real world evidence, yes.
You have an opinion about this?
Real world evidence, oh, that's again another lecture.
That's why-
Everybody's talking about real world evidence, what is it?
Yeah.
Yeah.
I like you, you're like I'm speechless.
Yeah, there are people in real world evidence. I ask a patient once a month and I have my real world evidence. And then there are others who say, well, you have to really interact with the patients like each and every day, that you have your real world evidence. Truth is in between, I don't know.
Yeah, but that's what I'm thinking, right?
But yeah, real world evidence, everybody is talking about it, and the registration authorities are more and more looking towards patient data, real world evidence data from the patient, also in the context of drug registration. I think, we will go that way, especially if our medication gets more and more sophisticated, more and more personalized, and also more and more expensive. Authorities will say, now you give me your evidence that you do something in your patient's daily life. So yeah, question is, how to get hold of it, and what pharma companies will do with it. But it will come, I think, in a more prominent way.
Okay, I have more and more questions, but how about you guys? You start the moments. Anything from the perspective of your project? Stroke you. Are you ready to register your app in DiGA?
Somebody mentioned Switzerland.
Oh, yeah, actually, I now understood the difference, right? Because it's in research, and they talk about global digital health,
Digital health hub, there's a lot of different names, right? But here we're talking about legal
here is a legal,
base,
yeah.
organizational base, you may argue about, it's not just technology, but it's the legal base for reimbursement, the reimbursement codes, the processes, which still need to be improved, but there is a path, there is a hope.
Yeah, that was different from the way, because they are in conjunction with the WHO. They actually try to promoting that in Africa, it's WHO globally. So they did issue with when they go to India, because India already have their own digital health. So when this one come in and wasn't well accepted by the WHO Indian office, let's just use it that way. But overall, that's the idea. It's a concept, or no, it's a database. Basically, it's a database. It is an online platform. They try to implement it in Africa, in all the different countries for them to adopt this platform. It's rather a platform.
Database platform.
Yeah, database platform.
Okay.
So what you just talk about is the app. That's the database platform. So I guess name you something, but
This, I
not-
mean, the apps are, at the end of the day, if we look at it from a data point of view, they are a source of data, which ideally goes into if you have it, a data platform, which contributes to your data stock.
Yeah.
But that's again another lecture. But it belongs to digitalization, of course, you know. For me, there are several components. But when we talk about digitalization, there's, of course, you know, the technology on the one side, which is there more or less. Then you have the data issue. What do you do with the data? How do you use the data? There is the organizational issue. There's the legal issue, for example.
Economic issue then,
There's
you
the
have, and
economic
even you may have political issue aspects of
Yeah.
influences, and then you may have social and ethical and attitudes of the stakeholders. So
Yeah.
I'm actually, we've been talking about PESTEL. You remember I introduced you PESTEL? P stands for political, E economics, S social ethical, and then another E is ecological and sustainability, because you need to think long term. And the last is L, which is legal. And if it all comes back together, then you may have a core. But if one of these components is totally not fitting your way of thinking or stopping you, then unfortunately you're not going to fly.
Yeah, it's difficult. And again, this is why I think, you know, this is good, because it's fairly simple compared to you know, the whole thing. And I think you have to start somewhere.
Yeah, so one.
Yeah.
And it's not just the technology,
it's not, you know, that's what I always tell to people, you know, it's not a technology discussion. It's not a technology discussion. It's all about that.